professor and consultant in oral maxillofacial at Kwame Nkrumah University of Sciences and Technology and Kwamfu Anochi Teaching Hospital in Kumasi, Ghana. As I said, he's currently the president of the West African College of Surgeons, and his past leadership position at the University of Kumasi included Pro Vice Chancellor, Director of the Office of Grants and Research, Provost of the College of Health Sciences, and Vice Dean of the Medical School, and Head of Department of Surgery. Mr. President, my president of the West African College of Surgeons, you have the floor.
Thank you very much, Professor Ngate, President and host of this conference of thoracic and cardiovascular surgery. My talk, I must say, is this work where I was assisted in putting this work together by a member of the team, the committee that is responsible for developing the surgical plan for the West African College of Surgeons, specifically Professor Manuel Ame. We did this committee work in collaboration with the Program of Global Surgery and, at Harvard, and Social Change at Harvard. And we, over there, as we've gone along, we've also gathered other collaborators. Next slide, please. Thank you. So this is these are members of the committee. Some of them have titles like Second Vice President, Assistant Secretary General. But if you want to translate them to the present day, the committee was first formed in 2017. But to the present day means that the Assistant Secretary General then is our current Secretary General, who's Professor Chibuala. Professor Grace Parkins, your name should be there because you remember you are the, oh good, there you go. So it's a pleasure, but your name should be on this slide. And then Professor Ngate was the chairman of that committee. When the committee was first formed, it became clear I did not represent all the specialties in the college. So others like obstetrics and gynecology, otorhinolaryngology, anesthesia, and ophthalmology were recruited. If it was being formed today, we would have recruited orthopedics also onto the committee. Next slide, please. So the West African College of Surgeons saw its role as really being to assist individual countries in formulating national surgical plans and helping to coordinate the development of these plans in those countries, and also helping to monitor implementation and doing evaluation of these programs. For some reason, the text is so small, but I blame myself for producing it. So West African College of Surgeons did not see itself as being responsible for the development of NSOPs in these countries, but rather to help facilitate both the establishment of these committees in countries and also to help fill the gaps as they became necessary. And of course, in our case, where our greatest strength is, can I stand here? The angle is not very good for my baseline information, and then we coordinate, the regional efforts in this regard. Is it my eyesight or the Philip? My eyesight or it's not good, eh? It's not sharp. The image is not sharp at all. So I know it's very tiny, but I should use to read. I because of my glasses, I always thought I'm blind, but yeah, very, very tiny. Anyway, so our role really is to just to coordinate what is taking place in various countries. Next slide, please. Next slide. Yeah. Anyway, so we decided to break up our work into phases, and thought that we would have an initial target of developing a West African surgical plan by the end of 2018, and then to target mainly 2 Anglophone countries and 2 Francophone countries, Ghana, Nigeria for Anglophone, and then Cote d'Ivoire and Senegal for Francophone. And after that, to reach out to other countries. So these were the 2 countries that we're targeting on. We tried to look at existing information from a baseline assessment. Wanted to look at published data, what was present in the ministries of health, the medical and dental councils, nursing councils, and other regulatory bodies. We would then go ahead and also do basic research, that's quantitative and qualitative research. Next slide, please. So diagrammatically, this is the phases that we talk about. Basically, do the initial data collection, and then have committee meetings throughout, and then define the role of WACS, and then help with implementation. The next slide, please. So, of course, this is a picture showing one of our first meetings. Next slide. And some of the meetings were held in person, others were also, a lot of them, majority of them were actually online. And this is a picture showing some of one of our members, Professor Ame, who had a privilege of attending a WHO and Harvard meeting, sponsored meeting in Dubai. And the idea was to work with others in different parts of the world to think through NSOAP and how it could customize for the benefit of West Africa. Thank you. Next one, please. And so out of that came a kind of they need to develop a strategy where they needed to have a baseline information and then go ahead and develop strategy. We've seen these slides over and over again in the previous presentations. Next slide, please. So at the time, let's go back, please. At the time, let's go back to the, yes. At the time, Senegal was, in West Africa, was the only country in green that had a surgical plan. Sierra Leone was in the process of developing its own. Nigeria was also developing its own. All the other countries did not really have any committees or plans in place. And so West Africa at the time was still quite deprived. And I'm sad to say that even as I speak, it's only Senegal and Nigeria which have surgical plans in place. All the others are taking baby steps. Next slide, please. Well, there's a lot of work still to be done. We still need to get all these countries which should promise, like Ghana and Sierra Leone, to actually act on what they're doing. I know that Côte d'Ivoire is working on a surgical plan, but there's still a lot to be done. Next slide. And of course, Senegal also, the work, the plan is in French. We need to try and get it translated so that it's accessible to the Anglophones. And so we still have many things still pending. In the course, of course, we realize that we need to get buy-in and partnerships from ministries of health, which have been emphasized, and then some of the private sector and other partners like Johnson & Johnson, General Electric, and others. We also, in our case, we need to engage other international bodies who have been our partners, and including one like Smart Train, which actually helped with the Nigerian ENSO plan. Let's go on, please. Next one. So what works again? How do we know if we are doing well? These indicators are well known. They are from the Lancet Commission. Need to have improved access, increased density of providers, need to increase the surgical volume, and reduce perioperative mortality, and of course, address the issue of financing, which has been emphasized over and over and over again. Let's see the next slide, please. So in West Africa, we estimate that, well, currently our population is about 420 million. Now, maximum estimate of surgeons in West Africa of all countries is about 20,000. Now that gives about one surgeon to 21,000 population. And so surgeon density is, you have about 5 surgeons looking after 100,000 persons. Let's have the next slide. So no, let's go back to the previous slide, no, the one before this. If you look at a target of say 20 surgeons per 100,000 population as the minimum Lancet indicator, we are currently doing 5 per 100,000. Then you can see that we are way behind. Of course, it varies from country to country. It varies within countries from location, whether you're in the city or in the rural areas, as the minister has shown. This is not what we need. Next slide, please. Yeah, next slide. Yeah. So we need answers to all these things. How far are the individual member countries moving along this? We need to have an indicator dashboard in which for every country we can fill in data for how well we are doing in reducing, say, expenditure and increasing surgical volume, and reducing mortality and improving access. Thank you. Next one, please. Well, these challenges have been spoken about, the perpetual funding issue. And so our committee, even though it's been in place since 2017, now it's so nice to blame COVID for everything. To say that because of COVID, things have not moved along for almost 2 years. But our different countries have not moved along with the surgical plans. And even those that have moved along with the previous one, please, previous one. Yeah, those that have even moved along have had to redirect resources away from surgery to address the challenge of COVID. So COVID, I would say, has offered 2 sets of challenges. I mean, on the one hand, there's been a dwindling resource, but at the same time, we have also lost some surgical providers. And so the issue of numbers has to be even looked at again. Those that we had are no longer the same, so we have to increase the output. And then, but COVID also offers us an opportunity to build our local systems, because COVID created the awareness of the centrality of surgery and anesthesia in addressing the problems of COVID. Because if adequately equipped hospitals had been set up throughout our various countries, managing COVID would have been much, much easier. Next slide, please. So we, as a college, need to move along this plan of making ourselves more relevant by really coming out with this surgical plan, which will provide a roadmap to help us strengthen surgical obstetrics anesthesia care in the region, and to help monitor and track the progress in a timely and reliable manner, and also to help us to review how well we are doing with our implementation and then change as needed. I mean, it's become very clear in this ENSO discussion that it's not a one-size-fits-all prescription. We are all feeling our way around. And I like the question that Professor Mushobuela posed. How different is it from other initiatives? It is essentially boils down to the fact that we lack access, we lack the resources, we lack the infrastructure, we lack the human resources, we lack the financing. It doesn't matter what name you put on the problems that face us in cardiothoracic surgery, in all specialties. The fact that we lack resources and we have not adequately committed resources to them in a holistic sense in the health system. So I think it is only when we begin to even see our own selves as surgeons as part of the bigger health system and move to improving the health system as a whole, that is the only way that our surgical plans will be fully implemented. I think it's, if we don't do that, and we keep harping only on what is important for surgery, I don't think we're going to make much progress because it will demonstrate insensitivity. COVID has shown that we must think more globally in terms of health, and surgery is a part of it, and surgery makes even dealing with pandemics easier. Thank you very much.
Thank you, Professor Peter Donko, for this exhaustive presentation. And yes, surgery, thoracic is part of surgery overall. If there is no lack, there is lack for infrastructure, human resources in surgery, it will affect thoracic surgery, of course. Thank you for that point. And if any comment from the floor, est-ce que vous avez des questions à poser par rapport à ce que le professeur Peter Donko vient de dire sur la chirurgie globale et le plan national, les plans nationaux en chirurgie et en obstétrique dans la perspective du Collège ouest-africain de chirurgie. Okay, if there is no comments from the floor, Professor Peter Donko, you have something to, there's no, your conclusion is nothing to have. Okay.
I have said everything I wanted to say, and I think I'm happy for us to move on. Thank you very much. So the next speaker is, in brief, the president of the African Association for Thoracic and Cardiovascular Surgery. He is a well-known cardiothoracic surgeon from La Côte d'Ivoire. He's held many important positions. One of the ones that I'm proud to mention, that he was also the president of the West African College of Surgeons. I think they have not shown you your bio, but they all know you. And I'm highly honored to introduce to us, welcome, there you go, the president of the Association, Professor Kofi Hervé Yangni Angate, pediatric cardiac surgeon from La Côte d'Ivoire. Professor Angate, thank you.
Thank you, Mr. Chairman. We have this great privilege to talk about Abidjan Declaration. Abidjan Declaration 2019 for open heart surgery development in sub-Saharan Africa. Accessibility, financing, and sustainability. I must confess that this declaration was a teamwork. It has been written and adopted here in this hotel in May 10th, 2019. And it has also been published in the official journal of our association, African Annals of Thoracic and Cardiovascular Surgery in 2019. As you can see on this picture, most of the surgeons, cardiovascular surgeons, leader in their own country was involved into that declaration. You can recognize Salvador here, even Wilfried is there, and Muhammadu Njai from Senegal, Ganji Wilfried from Benin, and Tipo from Congo. And there is a partner, an important partner, Mohamed Lee. He was also with us from France and others, cardiovascular. And what is the background of this declaration? The fact was based on some facts. More than 100,000 of those children born with congenital heart disease and or with rheumatic heart disease yearly will die within the first months of birth or in early ages because of no accessibility to open heart surgery in sub-Saharan Africa. The other fact that we expressed is that cardiovascular diseases have significant and increasing surgical burden, in particular in rheumatic heart diseases and congenital heart diseases in the African continent. In sub-Saharan Africa, cardiovascular disease burden is increasing, and it would double by 2030 when in sub-Saharan Africa, we're still facing lack of adequate functional cardiac surgery centers and no access to open heart surgery for a large majority of patients, where 6 billion people have no access at all to open heart surgery when necessary. There are 200,000 to 470,000 new cases of rheumatic heart disease every year. This is another fact. And in children with heart disease in sub-Saharan Africa, rheumatic heart disease is the leading cause of death during the first 10 years of life, with a mortality of 12.5% to 20%. And among the dead, more than 50% could have been saved if there were easy access to open heart surgery. And among the survivors, hundreds of thousands cannot access open heart surgery and will see their physical condition deteriorate until early death. And without any surgery, more than 80% of them may have lost life. In Africa, of the 50 million live births annually, at least 335,000 will have a congenital heart disease. Unfortunately, less than 5% of them will have access to open heart surgery. And what about the remaining 95%? Probably they will die because of no availability and no accessibility to open heart surgery. 1 in 3 children born with congenital heart disease will die within the first months of life. And whereas in sub-Saharan Africa, only a few patients have access to open heart surgery, despite a large need of open heart surgery. Approximately 3,000 to 5,000 new cases per year, and this per country in sub-Saharan Africa, including here in Côte d'Ivoire. And there is one center, it has been shown by the previous author, previous speaker here. There is one center for 120,000 people in North America versus only one single center for 33 million of people in Africa. I think this is a common picture in Africa overall. As a consequence of topping fertility and burden rates and no access of open heart surgery, congenital heart disease will remain a social problem in African continent and in sub-Saharan Africa in particular. And moreover, there is less than 1 adult cardiac surgeon per million population, compared with 7 adult cardiac surgeons in high-income countries. This is a tremendous challenge that we face. And in low and middle income countries and in sub-Saharan Africa mainly, cardiovascular diseases and other communicable diseases contributed to household poverty, and this is due to catastrophic health costs and the high level of direct payment faced by households. The last but not least fact is that the total economy loss due to cardiovascular disease in low and middle income countries, such as those in sub-Saharan Africa, was estimated at around $4 trillion between 2011 and 2015. This is coming from World Health Organization. And these represent approximately half of the economic burden of non-communicable disease and represent 2% of the GDP of our low and middle income country. At macroeconomic level, cardiovascular disease have a negative impact on the economies of low and middle income country. Those are the facts and the reality. And based on that, we are calling by this declaration to action and recommendation to government and other partners. And also action from African cardiovascular surgeons themselves. First of all, calling for action to our national government regarding human resources, promotion for at least 2 surgeons per unit, 4 anesthesiologists, 4 intensive care physicians, 2 perfusionists, 1 physiotherapist, and 1 respiratory therapist per open heart surgery center. This is one of the declaration. Regarding consumables, drugs, and medical equipment, allowing grants for kits for open heart surgery by our own country in Africa. And enabling supply of consumable and medical drugs by purchasing groups of specialized industry. Also, promotion of group to purchase for all consumable and medicines expressed by Center of Open Heart Surgery in Sub-Saharan Africa, and granting tax relief on all consumables, drugs, medical imaging, and medical equipment in country where it doesn't exist. The other point about action toward our national governments regarding infrastructures, building at least 1 open heart surgery center per country in Sub-Saharan Africa, which should include an outpatient unit, a cardiology unit with at least 30 beds, and also a medical and surgical intensive care unit of at least 10 beds. A medical imaging unit with a complete cardiac hemodynamics rooms and 2 echocardiographic Doppler rooms, a biology unit, and pharmacy unit, and a surgical block with at least 2 surgical theaters and 2 artificial heart lung machines. Regarding training program, development of fellowship program, and continuous education in thoracic and cardiovascular surgery, extension of the harmonized curriculum for fellowship in cardiovascular and thoracic surgery within West Africa to other countries in Sub-Saharan Africa, and the creation of specialties training program, including perfusionist and physiotherapy training program in Sub-Saharan Africa. Regarding funding, ensuring universal health coverage for all patients who need open heart surgery with a priority given to children age 0 to 15 years, so 15 years old, and benefiting from 2% of social funds of companies and industries established in our country. 2% of social funds coming from the companies and industries, national, established in each country. Allocating 0.1% of the national budget to enhance open heart surgery practice and accessibility in each sub-Saharan Africa. While 0.1% of the national budget, it can be done. Regarding also funding, budgeting for at least 200 open heart surgery cases per center, per country, annually from national governments in sub-Saharan Africa. Of course, developing bills and laws and decrees to facilitate open heart surgery practice in sub-Saharan Africa. Regarding our own action, our thoracic and cardiovascular surgeons, our additional social contribution will be to work towards the achievement of goals as follows. Decrease of at least by 1/4 the heavy financial burden of several medical evacuation for open heart surgery outside sub-Saharan Africa, in Europe, United States, with roughly cost is around 20,000 to 40,000 euro per patient. The reduction of at least 75% of travels abroad for open heart surgery because of excellent local heart care center in sub-Saharan Africa. Thank you all for your attention. And now I think the floor is open for comments and discussion.
Thank you very much, Professor Ngate, for that presentation. Maybe before you take your seat, I'll ask my first question. And looking at the current challenge, especially with funding that our African governments are facing, and the recommendation that every country should have at least one state-of-the-art center. Will you maybe in the meantime suggest an idea for some of the countries to work together to establish a center that may be open to subjects of those countries to begin with, and then later have one in each country? Will you consider that as an approach?
This is one of the approach, but when we discuss among the members of this association, the option was that it will be better for our population, a local population, to have at least one center. Of course, when you look at the need, you compare the need and the infrastructure, one is not enough, but we have to start from somewhere. So the starting point is one, but we have to move a little bit. Now, we are going to have a second center in Côte d'Ivoire. I know that in Ghana, Kumasi have started one, even if it's not fully autonomous, but something is on ground. That this can be, I think, beneficial for our population because the needs are enormous.
Any comments, questions from the floor, please? You were all part of the declaration, so you probably, any comments? Questions for Professor Ngate?
Of course, this declaration doesn't exclude any help from abroad, of course, but we as nationals and as Africans, we have to keep in mind that progress should come from our home, at home. Before going and ask money, help, support from outside, you have to do something in your own house. That's why we set it and we express clearly a declaration that say, okay, we have to take our responsibility, the government, the industries, the companies, locally, to see how we can move forward. I think those 1%, 1.1%, 0.1% of the budget, and it's not something that cannot be achieved. I know that in Burkina Faso, even in Mali and so on, something has been done. But we have to present to our national government the way we want things to be done.
So thank you very much. Zangate, thank you very much. Looks like everybody agrees with everything that you said there. So please, let us now move on to the roundtable discussion. Maybe I will invite, you don't have to, they can stay where they are and then make their comments. But the names I have are Mohamed Ali, MTT Ghana, Mohamed Ali from France, MTT from Ghana, M Awori, Kenya, M Agaji from Nigeria. So all the first four names start with M. I wonder whether that's cardiothoracic surgery's requirement. Yes, okay. Yes. No. All right. Okay. All right. And then there's Dr. Podonu from USA, Dr. Vervot from USA, and then Nutema from Zambia, and Kenja from La Côte d'Ivoire. All right. So why don't we start from Dr. Lee from France? Can you pass the mic to Dr. Lee, Mohamed Lee?
Merci beaucoup. Je vous remercie. Je parle en français. Je suis désolé, je devrais être parmi vous, mais le Covid a décidé autrement. Est-ce que vous m'entendez?
Yes, yes.
OK, très bien. Je remercie sincèrement les organisateurs, professeur Ngate, et j'ai suivi depuis hier tous ces débats. C'est vraiment important de savoir ce qui se passe de là où je viens, même si je suis plus de 20 ans en France, où je suis actuellement chef de l'unité à Nantes, mais mon esprit est toujours en Afrique. Bien sûr, on parle des choses importantes puisque c'est les problèmes de santé dans ce continent, où on parle aussi de créer actuellement, après la conférence, la déclaration d'Abidjan, de créer des centres de chirurgie cardiaque à cœur ouvert, qui pour moi est une chose importante. C'est très important de savoir d'où on part. Est-ce qu'on a réglé certains problèmes ou encore certains problèmes persistent? C'est très contextualiser la chirurgie cardiaque ou la prise en charge des cardiopathies en Afrique. On sait que c'est des systèmes un peu difficiles où il y a une approche et une compréhension parce que c'est l'intrication entre la médecine curative et la médecine de santé publique, elle est encore pas très bien claire et tout est à la charge de l'État ou à la famille. Donc, je vais juste dire que oui, c'est important, mais il faudrait juste qu'on voit un peu comment on peut pérenniser ce processus. Certainement qu'après la formation dans tous les secteurs, et à mon sens, il ne faut même pas oublier, ce n'est pas que le chirurgien, hein, les anesthésistes, les autres médecins et les paramédicaux, qu'il ne faut pas oublier. Parce que depuis plus de 20 ans que je pratique cette activité et en Afrique et ici, j'ai compris que ce n'est pas le chirurgien le plus important en fait. Il est le capitaine de l'équipe, mais c'est une équipe complète. Et très souvent, on oublie de parler l'essentiel, c'est-à-dire le rôle de ces infirmières qui sont en réanimation, qui prennent en première ligne les malades. Bien sûr, il faut accompagner la création de futurs centres, mais il faut éviter de ce qui est arrivé à l'Institut Cardio d'Abidjan. Et il faut éviter aussi de ce qui arrive aujourd'hui au centre public maghrébin. Je suis formé en Tunisie. C'était, par exemple, l'exemple sous où on faisait plus de 400 patients. Tout le monde était formé dedans. Même toutes les activités actuellement, si vous le regardez de près, c'est dans les cliniques privées que ça se passe. Bon, il faut éviter ça. Il faut s'organiser aussi. Pour moi, c'est exactement ce que je défends depuis toujours, c'est de mutualiser les efforts pour arriver à régionaliser les centres qui vont être créés, à créer donc des très grands centres dans les régions d'Afrique, peut-être 4 ou 5, qui doivent être en hauteur par rapport à d'autres centres qui feraient peut-être moins d'activité ou moins de complexité. Ceci permet d'emblée de supprimer la tentation de concurrence, de fausse concurrence, bien sûr. Et puis, je pense que c'est le rôle de l'académie aussi d'harmoniser, de vanter l'harmonisation. C'est important, c'est pour ça que aussi la création de l'académie, elle est aussi importante. Je prends l'exemple de ce qui se passe aujourd'hui en Occident. Que ce soit aux États-Unis ou même en France, il y a plus de 11 centres. La réflexion, elle est toujours, même au niveau de la Société française de la chirurgie cardiaque, elle nous pousse à dire qu'on va de toute façon fermer 4 centres ou 5 centres. Jusqu'à maintenant, il y a des centres qui sont en train de se dire ah, peut-être c'est nous, peut-être c'est l'autre, peut-être c'est pas clair, mais en tout cas, c'est le chemin à peu près de l'État, de la société même française de chirurgie cardiaque. Et quand on voit aussi des publications les plus récentes, on voit clairement que la régionalisation des centres de chirurgie pédiatrique c'est corrélé avec des taux de mortalité plus faibles ou les coûts qui sont plus faibles, mais aussi c'est dû en fait à l'augmentation du volume d'activité. Et dans ces centres d'excellence aussi, il y a un tri qu'on ne doit pas faire parce qu'il y a des cas complexes et il y a surtout les nouveau-nés qui ont besoin d'un environnement très particulier pour être opérés. Donc, on ne peut pas donc, rajouter un tri ou en tout cas favoriser peut-être à avoir plus de taux de mortalité pour ces cas complexes parce qu'on ne les prendrait pas en charge ou bien qu'on dira ben, on a fait ce qu'on pouvait. Parce qu'aujourd'hui, il y a tous les moyens pour ne pas abréger la vie des patients, même les plus complexes. Alors, il faut avoir une idée pour voir comment on peut réduire le coût du fonctionnement. Alors, c'est par cette volume d'activité qui va permettre donc de baisser les coûts parce qu'on va demander à des laboratoires parce qu'on va avoir une centrale d'achat probablement avec beaucoup de demandes qui va baisser, qui va rendre probablement des taxes. Mais à terme, pour nous, aujourd'hui, je pense que c'est de créer des sociétés d'approvisionnement, des implants, des valves, comme ce qui est demandé aujourd'hui dans le sommet Europe-Afrique, que l'Afrique crée de vaccins ARN. Donc, cela, il faudra qu'on y arrive aussi, c'est-à-dire qu'on fabrique nos implants, qu'on fabrique nos tuyaux, enfin notre tuyauterie, peut-être même ce qu'il faut en CEC. Alors, troisième chose qu'on pourrait faire, et ça c'est le rôle peut-être de l'État, c'est une exécution de programmes assez rapidement quand même de micro-assurance, parce que je pense que la charge ne peut pas être totalement sur l'État et sur les familles. Moi, je ne vois pas au milieu, il n'y a pas grand-chose. Et même ceux qui ont des mutuelles aujourd'hui ou des assurances, ils vont aller ailleurs. Ils vont aller au Maroc, ils vont aller en Tunisie, ou bien ils vont essayer de venir en France. Alors, autre chose, je pense, à mon sens, qui est important, c'est de créer des ailes de bienfaisance. Les fondations, parce que pouvoir relever des fonds pour aider notre population d'indigents, on en a beaucoup. On a beaucoup d'indigents et il faut qu'on puisse les opérer aussi, et ça, les fondations peuvent aider. Et avant de finir, je voudrais qu'on s'interroge tous aussi au rôle que je pense très important que devrait avoir le secteur privé dans la prise en charge de la santé en Afrique et surtout dans la prise en charge de cardiovasculaire. Et là, il ne faut pas mettre tout dans les mains des gens qui vont organiser le privé et que nous soyons des gens qui feront la prestation. Non, c'est que je pense qu'il faut un pacte d'actionnariat de médecins, de chirurgiens eux-mêmes qui créent ces environnements, parce qu'on sait que quand on a un environnement privé, on a souvent des rémunérations, on peut attirer le personnel le mieux formé, et puis en plus de ça, ceux qui ont des mutuelles et donc des assurances qui peuvent partir, ils auront un cadre à peu près le même que ce qu'on nous propose pour éviter ces fuites donc de patients. Voilà, c'est des remarques que j'avais en tête, que j'ai toujours en tête. Je sais que je vais intervenir demain aussi et c'est la chance que j'ai pour parler un peu de l'humanitaire. En tout cas, voilà, je vous remercie.
OK. Thank you very much. Merci beaucoup. Merci beaucoup. We invite Dr. Tete from Ghana, and we take all the micro.
Thank you very much for the opportunity to comment on this important program of sustainable development of cardiac surgery in the sub-region. I must say that this is very dear to my heart because we must do something. Our generation must do something, must establish something for the next generation to come. Now, I believe that for a sustainable cardiac program in the sub-region, this rests on 3 pillars. We have mentioned them already. One is funding, the other is infrastructure development, and the last one, or the third one, has to do with human resource development. And these pillars, I believe, rest on a foundation. That foundation is the political will. If the political will is not there, these pillars will not stand. Because the political will has to help develop all these 3 pillars to be able to stand to support a sustainable development of cardiac program in the sub-region. And just let me take them one by one. We have discussed most of them already, but then a few things I would like to just mention about these 3 pillars. Now, we talked about funding a lot, and Professor Ngati has mentioned in the Côte d'Ivoire Declaration about how the cardiac program could be funded by taxing industries. And that is what I'm really supporting. We must have innovative ways. We, the surgeons, those who are in the industry, those of us who are practicing, should come together to find innovative ways of raising funds for this. And we can present this to the government for support support and helping us to achieve what we have decided. In Ghana, we've tried several things. We have announced to the population to donate at least maybe a bottle of Coca-Cola every year. All working population in Ghana, they donate that. If we have about 2 or 3 million people doing that every year, that will suffice for operating on everybody who comes to the center without having to pay. But there's no political will to support this. We have the Ghana Heart Foundation where industries, individuals donate to. That is what is actually supporting heart surgery in Ghana now. So funding is one pillar, one great area which has to be well researched into, but individual countries, looking at the environment you find yourself in, and then works up something so that it can be sustainable. It's not a one-time thing, somebody donating something to you, and then that's it. It should be something that you can rely on, that can carry you through for the future. And the next thing is about a human resource. And I thank God that we have the West African College of Surgeons, and we are training cardiothoracic surgeons in that program. But a lot needs to be done. We have to do more, because the training we are giving to our residents now is not enough. We need a lot of collaboration with the developed countries. They need to improve on their knowledge base. We need an environment that can also help with research, because without knowledge, we can't get anywhere. And I believe that the current what is happening now in the sub-region, the current state of affairs of cardiac surgery, we are yet to start. And for me, I believe that if we can just perfect on the basic things, treating very basic congenital heart diseases, maybe just ASD, VSD, maybe tetralogy fellow, a few of the basic things, perfecting and making sure that we are able to save our children from those basic surgical procedures before progressing to the complex ones. If we can perfect that, develop centers that can perfect in those things, it will have a long way. And about human resource again, one thing that I have in mind to talk about is leadership. We have a problem of leadership in our subject, and where most of us as cardiothoracic surgeons, we want to show ourselves off. And once we become known, or we want to become known as those that can do this, can do that, and it's not helping us. We need to provide good leadership that will pull along other colleagues, that will encourage other colleagues to also come along with us. But if we want to play that role where you are the only person who wants to be seen, a lot of people will shy away from you, and that discourages people from helping to make the program successful. So leadership is another problem that I think human resource has to look at very, very well. And this leadership is what is going to help us establish the centers, making them work, training more of the residents to be able to expand to other areas. So if we are able to provide leadership in one center of excellence, and that is good leadership, you can easily expand. But without good leadership, it's a problem. So for human resource, I'm looking at making sure that we provide avenues to increase knowledge, surgical practice, collaborating with other centers outside our region, making sure that our trainees are well trained, making sure that they acquire the requisite, whatever they need to know abilities to be able to do enough for the sub-region and research into things that are local to us, those that are peculiar to us, doing research and making sure that we are able to help our population. Then when we come to infrastructure, what are we talking about? The government must come in to help us to build infrastructure, to build the supporting services that we need to be able to stand. And a lot of the times, the government may help put up these things, but maintenance becomes a problem. And as surgeons, especially we are supposed to be the leaders of the team, that maintenance culture needs to be looked at again, because if we want a sustainable program, we need to maintain what has been given to us. And a lot of these things also has some connection with funding. We need to source for funds to be able to maintain what we have. Because if patients are not paying enough, we cannot maintain what we have. So maintenance is a problem, making sure that all the supporting services that we need are provided for us. Pharmacists, lab, and everything are there to help us, the infrastructure to work. These are the three pillars that I have in mind. I don't want to talk too much, but then about all these things, that if the government does not come in to support us with a goodwill to make sure that the programs we have work, we will do our best. We'll do everything we can, but we may not go anywhere. So thank you for the opportunity.
Thank you very much, Dr. Tete, for that very elaborate input. Let's move on. Dr. Awori from Kenya. Over there. Dr. Agaji from Nigeria. Over there. Dr. Podonu from USA. Dr. Podonu. Yeah.
Yes. Good afternoon, I guess. In Abidjan, I'm speaking from Boston. I think all the comments that were raised are very good comments. Infrastructure, funding, and human resources. I think we have to be quite creative in terms of how we start to address those three pillars, which Professor Tete mentioned. I will go over some of those in my talk. I don't want to give too much away, but I think there are some creative ways we can start to think about how we educate, for example, our trainees, using simulation, using e-learning, using telemedicine. So I think there are some innovative ways that we can now start to bring into our traditional ways of maybe training, for example. In terms of funding, I agree that the government has to play a primordial role. But again, I heard Professor Lee mention microfinancing, which I think is another good way to raise funding. But we also have to think about establishing public-private partnerships. It doesn't always have to be the government. It can also be public-private. And as Professor Ngate said, we have to start at home. So we have to get our house in order, right? And then if we get our house in order, we can reach out to the private, to the private sector, to assist. And then we can also ask the government to play its share. So I think we're gonna have to be a little bit more creative in how we start to look at this, those three pillars that Professor Tete mentioned. But I think I'll discuss a little bit more in my talk. Thank you.
Thank you very much, Dr. Podonu, which sounds like a very familiar Ghanaian name. Yeah, nice to see you on the other side.
Thank you.
Dr. Vervot, USA. Thank you.
Good morning, everyone. And thank you very much for both the association as well as Professor Ngate for the invitation. I first want to say that the declaration is a great example, also how we're all here together now for the conference, but also how we as a cardiovascular surgical community can come together and really tackle some of these issues, which are not just affecting us as a cardiovascular surgical community, but are really affecting most primarily our patients, our economies, and everything, and so forth. And with regards to solutions, I also think that we have to kind of look at it from that angle as well, recognizing that this is a health systems issue as opposed to a very siloed aspect of a functioning health system. And so because of that, there's 2 points that I kind of want to emphasize, mostly from my background in terms of health policy and health economics work, which are, one, the policy side of things, and then secondly, the health financing point. And some of these points have already been discussed previously in some of the previous talks, as well as by Professor Lee and Professor Tete. But I just want to kind of emphasize that, just given the importance thereof. So with regards to the policies and regarding health policies at large, I think one major issue is obviously part of the conversation this morning surrounding National Surgical Obstetric and Anesthesia Plans, or NSOPs, is that these are creating momentum within the field of global surgery that allows us to really position ourselves as a surgical community within the broader global health sphere, within the broader national health plans and so forth, and really ensure that there is political commitment that there eventually will be funding as well for strengthening access to surgical care. But unfortunately, despite the fact that more and more countries are developing their NSOPs, there's very few of the NSOPs that are currently already in place that specifically mention cardiac surgery. Now, before the pandemic, when there were 6 NSOPs launched, there was only one NSOP, the one from Zambia, that specifically mentioned the need to strengthen cardiac surgery, how much it would cost, how many surgeons they would need, et cetera, whereas the other NSOPs, unfortunately, didn't really talk about it. So there was no clear goal. There was nobody actually at the table to ensure that cardiac surgery was being discussed as part of these NSOPs. And moving forward, obviously, in great thanks to the association and by the West African College, we have to ensure that cardiac surgeons and other personnel who are involved with cardiac teams and open heart surgery are actually at the table, so that when future NSOPs are being developed and eventually will get funded, that cardiac surgery is a part of that, and that we're not addressing everything else, but then forgetting about cardiac surgery until much later. Now, a big issue with regards to the fact that cardiac surgery wasn't really part of that is, one, in many countries where NSOPs have been developed, there was simply no cardiac surgery at baseline. And so it's hard to have somebody at the table if there's no baseline cardiac surgery. And I think that's where societies like the African Association can really come in, as well as the West African College. But at the same time, there's also the importance for us to recognize that we have to be consistent in our messaging and collaborate in terms of the advocacy efforts that we're putting out. And Professor Tete mentioned that as well, in the sense that there sometimes has been a bit of a trend where individuals or individual organizations want their name or their work to be specifically highlighted, whereas for us to really reach policymakers to ensure that there's an impact on individual health policies like NSOPs, we have to ensure that we're doing this through a common platform, through a collective voice. And so those are 2 kind of major points from a policy point. Now then, from the financing perspective, there is obviously much more to financing than just investing in cardiac surgery, although that is a very important point. And I think that's greatly illustrated by kind of the current mismatch in terms of the global funding for individual diseases or individual priorities within global health. That I'll show visual examples of that later in my presentation. But just to briefly state is that while cardiovascular diseases, as we all know, are the leading cause of morbidity and mortality worldwide, compared to conditions like malaria, HIV, tuberculosis, and so forth, there's only a very small proportion of global health funding dedicated to cardiovascular diseases, with less than 2% dedicated to non-communicable diseases at large, whereas over half of global health funding is dedicated to these 3 infectious diseases. And so there's already that mismatch between what's actually going on the ground versus what is being funded at a global level. Now, from a political perspective, then there are unfortunately a lot of misperceptions that are still taking place, and that is partially because of a lack of data, it's partially because of a lack of advocacy and so forth, but also simply because there's really kind of that mismatch between, or that disconnect between the clinical environment and the policymakers and the funders. And some examples of that are just simply the costs of cardiac surgery, where it's oftentimes said that cardiac surgery is too costly, whereas many countries across the globe, with many low and middle income countries across the globe, are currently performing cardiac surgery at just a few thousands of dollars per patient, which greatly emphasizes that there is the opportunity to reduce costs. Secondly, with regards to the cost effectiveness, it's oftentimes said that, okay, while we invest so much money in certain conditions, it might be worth it if eventually the burden that is averted is actually cost effective from that perspective. And there is limited data on there from cardiac surgery, but from a pediatric cardiac surgery perspective, it's already been shown that it's very favorably cost effective to invest in that, especially compared to, for example, mosquito nets or antiretrovirals, et cetera, even though they also should be prioritized, of course. But then thirdly is also the macroeconomic impact. And I think some of the talks, both in the Abidjan Declaration as well as with some of the previous talks, have already shown that given the vast burden of cardiovascular diseases, not treating that, not investing in that, will ensure, or will unfortunately result in the fact that we are missing out on great socioeconomic progress, just simply because, unfortunately, patients with congenital heart defects, rheumatic heart disease, et cetera, die too early or die too young before they're able to contribute to their communities, to the economies, and so forth. And so with that, I kind of want to close with obviously the importance of recognizing that as a collective voice, we have to ensure that we keep pressuring and keep making policymakers and funders aware of some of these issues to ensure that while we're thinking about everything that's happening or surrounding a patient within the operating room, in the intensive care, et cetera, that we're also connecting that with the broader health systems issues with regards to policies, financing, and so forth and so forth. So thank you again, and I look forward to speaking later on this as well.
Thank you very much, Dr. Vervoort. Dr. Mutema. From Zambia.
It seems Dr. Mutema
Okay.
was disconnected.
All right. Is Dr. Kenja, Côte d'Ivoire? Thank you.
Merci, Monsieur le Président. Je pense qu'après tout ce qui a été dit, je pense que je ne veux pas refaire la table ronde, mais ce que je retiens, c'est que nous sommes tous dans un environnement où nous sommes convaincus que le besoin en chirurgie cardiaque à cœur ouvert est énorme dans nos différentes régions. Et les solutions que nous avons pour faire face à ces besoins sont diverses. Mais nous sommes confrontés surtout à un problème de financement. Mais au-delà du financement, je pense que c'est le problème de la volonté politique. C'est vrai qu'aujourd'hui, nous avons l'exemple de l'Institut de cardiologie, où la structure a été mise en place, elle a fonctionné, et aujourd'hui, les choses ne vont pas dans le sens qu'on souhaite. Mais je pense que c'est une analyse qui n'est pas totalement juste. Quand il y a eu la volonté politique, les moyens ont été trouvés pour que l'Institut puisse être mis en route. Et le personnel a été formé, il a été motivé, les interventions se sont faites. Le problème qu'il y a eu par la suite, c'est que l'Institut n'étant pas adossé à un fonds, lorsque celui qui a eu la volonté politique a disparu, l'Institut a commencé à battre de l'aile. Donc, ce qu'il faut, c'est d'abord la volonté politique. Ensuite, les financements suivent. Une fois qu'on a les financements, on va financer d'abord les infrastructures, on va financer les équipements, on va financer les consommables, on va financer la formation. La formation est fondamentale. Il faut former. La chirurgie cardiaque, c'est l'une des seules disciplines où on parle vraiment d'équipe. Quand on parle, le professeur Lee en parlait tout à l'heure, quand on parle de chirurgie cardiaque, on voit chirurgie. Mais en fait, le chirurgien, c'est 50% au maximum de l'activité en chirurgie cardiaque. Le cardiologue, il est fondamental. Le réanimateur, il est fondamental. Le perfusionniste, je dirais même qu'il est aussi fondamental parce que c'est lui qui permet aux patients de vivre pendant toute l'intervention. Les infirmières, les instrumentistes, et on oublie le personnel de soutien, les biologistes, la radiographie, l'administration, les kinésithérapeutes. Donc, tout ce monde-là, la formation, elle est indispensable. Le problème, c'est que quand on parle de financement, on voit l'achat de matériel, l'achat de ceci. C'est effectivement, si vous avez une très bonne équipe chirurgicale et que vous n'avez pas le matériel, vous n'avez pas les consommables, vous ne pourrez rien faire. Mais on peut vous mettre, parce qu'il y a des missions qui se font dans nos structures avec notre équipement, avec une partie de notre personnel. Pourquoi nous n'arrivons pas à décoller? C'est le problème de la formation. Donc, il faut financer la formation. Et je pense que si la formation est financée, on peut espérer faire quelque chose. On a tendance à choisir la solution la plus simple, les évacuations sanitaires. Effectivement, les évacuations sanitaires permettent de résoudre une partie du problème, mais ça concerne essentiellement des individus. C'est ce qu'on appelle le financement de la dépense. On finance la dépense parce qu'on fait sortir des devises, alors qu'il faut financer l'investissement. Financer l'investissement, c'est faire en sorte que les interventions puissent se réaliser dans les pays d'origine, de telle sorte que les patients, les enfants puissent être opérés dans leur environnement, avec leurs parents. Ça permet de donner du travail aux populations locales. Ça permet également de faire en sorte que cette activité soit une activité sociale. Donc, pour moi, la chose la plus importante, c'est la volonté politique. Une fois qu'on a la volonté politique, on trouvera le financement et on pourra avancer. Les ONG viennent en appoint. Quand on a ouvert l'Institut de cardiologie, ce qui a été fait, l'État s'occupait de prendre en charge les Ivoiriens. Et il y avait des hommes, une ONG suisse qui prenait en charge les enfants qui venaient du Mali, du Burkina Faso, du Sénégal. Aujourd'hui, tous ces pays-là ont des centres de chirurgie cardiaque, ce qui est une très bonne chose. Parce que l'existence de ces centres-là nous permet progressivement d'évoluer vers le ratio qu'il faut pour la chirurgie cardiaque. Voilà. Donc, il faut la volonté politique, il faut que nos États prennent des responsabilités et il faut qu'en plus, il y ait des opérateurs économiques, du privé, les institutions régionales, sous-régionales qui viennent en appui. Mais vous savez que tous les États sont un peu jaloux de leur indépendance. Donc, c'est toujours difficile de globaliser des choses. On a des institutions économiques, mais pour arriver à des institutions de formation, ça, c'est un autre pas. Volonté politique, financement, formation, je pense que si on atteint ces deux objectifs-là, on sera sur la voie. Je vous remercie.
Thank you very much for all those comments. Many pertinent issues have come up. And one thing that I like very much from the last speaker was the need for ethics. And then the mention by leadership. I think we are all appealing for resources. But we must also think carefully about how we manage the resources when they become available. Also, let's think about volume. How many cases are we going to treat in these centers that we are going to create? And how will that contribute to the expertise, which is so essential to quality care? Very, very important. These are matters that we must address as we go along. And then, of course, the need for partnerships and great collaboration in getting our case forward. So I'll say thank you very much, all of you, and for your contributions. I will bring this session to a close, and I will invite the next chairman to take over for the next round of the discussion. Thank you very much.
Pour les voyageurs, ne sont pas tous des nationaux. La pandémie actuelle impose des vaccinations ou encore, je ne sais pas quoi. Dans tous les cas, il faut s'approprier les règles en vigueur. Si bien que j'ai demandé à l'organisateur de s'occuper de vous, de telle sorte que les papiers sanitaires, médicaux, ainsi de suite, soient à jour afin que vous évitiez d'être inscrit avec les bureaux des droits. Il ne faudrait pas qu'on vienne me dire, vous êtes venu en Abidjan, et dire ensuite que je retourne avec des difficultés. Je ne veux pas ça. Tel que vous êtes venu, tel que vous devez être chez vous. Donc, monsieur l'organisateur, il faudrait faire de telle sorte qu'on ne puisse pas parler de quelconque problème de nos voyageurs, qu'ils soient d'Afrique ou d'Europe ou d'Amérique. Merci. Merci. I was telling them that because of pandemic, I don't want any trouble with anybody. My guests have to be treated clearly without any disturbance. As they came, I want them to go and be comfortable in the plane and the home. Safe God, safe journey. That is my objective. So they will take care of you and everybody will be fine. Okay? Thank you. Donc, ceci étant, la prochaine section, c'est ça, d'après le programme. Je suis. La prochaine session aura trait à. OK. Ah. This next session will be on global cardiac surgery implementation in Africa. The chair was supposed to be Makasa and Professor Abidjan Declaration from the United States. Are they on site, please?
Professor, I'm here, but we are having internet connectivity problems, okay. and I'm also running the call in the hospital. I kindly ask if I could be excused and if there's anybody who could stand in for us or for me. Thank you.
So what can be the next step? Will be there or not?
No, I'm not going to be available. I was just waiting to pass on this message because I texted you and I didn't get feedback. So I came to just see if I could pass on the message. Yes.
See you. I appreciate. Thank you so much. Professor Yajit Yoganathan is not around. Okay, it's not around. So let me introduce to you the next speaker. May I have this bio, please, on the screen. May I have the bio of Professor Jack Bodonu on the screen, please?
Sure, just allow us a couple seconds, please.
Professor Bodonu is an American in the United States. He works in cardiac surgery. He's from Harvard Medical School. And he's quite well-known surgeons on aortic surgery. He published a lot, a textbook on his experience, his extensive experience on aortic aneurysm and aortic valve replacement, and even new technologies. Is very involved in innovative procedure in cardiac surgery in the world. May I say also that he's very involved in the development of African Association of Cardiothoracic Surgeons, and he wants to support our association for a database from CTSNet. And he found it is very interested in the global cardiac surgery capacity development and global health system innovation, addressing rheumatic heart disease, and use of simulation and training next generation of cardiovascular specialists. As I said, is a surgery faculty member at Harvard Medical School and a professor of surgery at the University of Health and Sciences in Ghana. He's from Ghana. As I know that his father, his family are still be in Ghana proud. May I congratulate them for giving to us. Dr. Bodonu is a well-known cardiac surgeon who has expanded his knowledge from Africa to United States. He is the editor of newly released textbook, Global Cardiac Surgery Capacity Development in Low and Middle Income Countries. And we will be able, in a few minutes to come, to discuss and to present to us, after his presentation, his book on global cardiac surgery development in Africa. Professor Bodonu is also involved into our webinar activity by the university, African University, from cardiac and thoracic surgery. He was one of our leaders, a best speaker at the inaugural webinar conference. Professor Bodonu is also a leader in the Society of Thoracic Surgeons and the American College of Surgeons. Our keynote address lecture is Professor Bodonu Jack, and he will talk about the role of cardiac surgery in global surgery and global health in Africa, capacity building and innovation, data sciences, advocacy, and telemedicine. Professor Jack Bodonu, I have the privilege to give you the micro for 1 hour if you want, 2 hours if you want, the day old. But I think you are a wise man. You will talk just to talk and just to let me know or to let us know the fundamental and the essential that we have to learn from your lecture. You have the floor. Thank you so much.
Thank you, Professor Ngate, for this warm welcome. And I would like to thank the Association for Thoracic and Cardiovascular Surgery for inviting me to give this lecture. I'm going to share my screen. Can you all see my screen?
Yes, we see that it is.
Okay, I'm going to
make it bigger, please.
Okay. Are you able to see it now?
Yes, wonderful.
Okay. Thank you. So good afternoon, I guess, in Abidjan, and it's good morning here from Boston. It's a pleasure to be with you. Unfortunately, I could not make it in person because of COVID restrictions. I hope probably the next meeting, I will be able to be with you in person. So again, I want to thank you, Professor Ngate, for the warm welcome. And I look forward to sharing over the next hour a vision on how we as cardiothoracic surgeons can build the future that we want in Africa. For this lecture, I do not have any conflict of interest. So I thought many of the speakers have spoken brilliantly about what we need to do to increase capacity building in Africa. We've talked about financing, we've talked about infrastructure, we've talked about human resources. And this has been a recurring theme over the last couple of years of how do we build sustainable programs in order to take care of our populations. So I would like to share with you some thoughts on how we can use new technology, novel technology, to kind of bridge the gap between those three things, those three pillars that Professor Tete had mentioned. So I think that it is very clear that we need to train more cardiac surgeons. We need to train more residents. We need to train a workforce that is dedicated to treating cardiac disease. We also need to develop our research capacity within Africa. In many countries in the West, for example, in the US, we have what we call the NIH, which is an organization which funds research. So I think one of the things that I think we need to do as a society and as a people is to start to look at ways to create research, research infrastructure in terms of funding research, to develop local innovation within our countries. We need to think about using new tools like telehealth. For example, right now I'm giving you a lecture on Zoom. The same medium of Zoom can also be used, to give lectures, to provide training. And we need to start using some of those tools. And finally, I would like to talk about collaboration, because I think collaboration is going to be the key ingredient for us to progress as a people. We cannot do this individually. We cannot do it by ourselves. We're going to have to collaborate. And by collaboration, I mean South-South collaboration, collaborating amongst African countries, and North-South collaboration, collaborating with Europe, collaborating with the US, collaborating with Australia, collaborating with South America. So those will be the themes that I'm going to talk about in my talk. And I hope that by the end of the lecture, we will have at least some principles in place going forward. So we know that the global burden of cardiovascular disease is huge. It's the #1 leading cause of morbidity and mortality, globally. In Africa, rheumatic heart disease continues to be a problem. We have about 34 million cases globally, with most of the cases in Africa. And we also know that 1 in 3 of the deaths concerning cardiovascular disease are related to cardiovascular disease. But we also know that 80% of those deaths occur in low and middle income countries. So the impact of cardiovascular disease to our health system is huge. It's about $50 billion per year. And I am sure that if we drill down further, we may find that it's actually more than that. Rheumatic heart disease continues to be a burden in Africa. Not too long ago, in the early 1920s, 1930s, my current institution, Beth Israel Deaconess, was the haven for rheumatic heart disease. Their number one inpatient disease, or ICD code, which is what we will see in the US, was for rheumatic heart disease. And in 1973, the Good Samaritan Hospital, which was then the leading hospital for patients with rheumatic heart disease, it closed its doors because there were no more patients. They had no more patients with rheumatic heart disease. But that's not the case in Africa. We still have quite a lot of rheumatic heart disease. And so I think part of our task will be to be innovative, to find new ways to diagnose and treat this condition. We've talked a little bit about policy and advocacy, and it is quite important for us to continue to be advocates for cardiac surgery, for rheumatic heart disease, for congenital heart disease. The WHO has already, in its 71st amendment, agree that rheumatic heart disease is a priority and should be dealt with. We know that rheumatic heart disease is an infectious disease, but it's the least funded of all the infectious disease. And so advocacy is key to continue to bring that message to the forefront, to get the world bodies more inclined to start funding rheumatic heart disease. So I cannot overstate the importance of advocacy in rheumatic heart disease care. Heart failure is a byproduct of many of these conditions of rheumatic heart disease. We have about 663,000 cases of heart failure that result from rheumatic heart disease. And because we do not have robust data collection within our continent, it's possible that that may even be more in low and middle income countries. So to address cardiac surgery disease, our priority should be on these three things: rheumatic, ischemic, and congenital. Rheumatic, we have millions of people who need surgery. Congenital, we have quite a huge burden in Africa that also needs surgery. Ischemic, we are beginning to see that as lifestyles have improved, we're beginning to see more ischemic heart disease also within our continent. So we definitely have to prioritize those three things, particularly rheumatic and congenital. Now, when we drill down into what it takes to set up a cardiac surgery infrastructure, we've already touched on some of those points already. Infrastructure and workforce. How are we going to build? How are we going to generate that workforce? How are we going to train? Who is going to finance? Is it out of pocket? Is it the government? Is it microinsurance? Is it NGOs? How are we going to deliver the care? And how are we going to monitor, and how are we going to evaluate? Because we need to be able to monitor and evaluate and collect data on what we're doing. We've also touched on the accessibility of cardiac surgery care. We know that in sub-Saharan Africa, there is 1 center per 33 million people. In Asia, it's 1 per 16 million. We know that in high-income countries, they have about 180 times more cardiac surgeons per ratio to population than in Africa. But we also know that it is possible to do cardiac surgery for $1,500 or $2,000. So what do we do? How can we increase the capacity of surgeons in Africa? We know that the ratio of adult cardiac surgeons in low and middle income countries is about 0.04 per million. In high income countries is 7.15. So again, there's a big gap. There's a big workforce gap that needs to be filled. Same with pediatric heart surgery. The gap is huge, 0.07 pediatric surgeons per million in Africa versus high income countries where it's about 9.5 per million. So again, there is a gap that needs to be filled. And how are we going to train the next generation of cardiac surgeons, and how are we going to fill that gap to take care of the 1 billion people in Africa? Now, we've talked about cardiac surgery, but cardiac surgery is part of surgery. So global surgery in itself, if we drill down on the numbers, we realize that we need about 313 million surgeries take place globally, and only 6% of those surgeries take place in low and middle income countries. We also know that there's about 5 billion people that do not have access to surgery, and that's including cardiac surgery. And we also know that less than 1% of the budget is allocated to surgery. So again, there's big advocacy needs that are required to increase the advocacy on funding surgery per se. We also know that when you have less than 20 per 100,000, 20 surgeons per 100,000 people, it's also related to the maternal mortality rate. Earlier on, Professor Donko mentioned that in West Africa, we have about 5 surgeons per 100,000 people. So obviously there's a gap that needs to be filled. And we cannot overemphasize that. Now, what are the numbers? Again, you need to know what the numbers are. And so we need probably about 2.2 million additional surgical staff to meet the demands of surgery, at least in Africa. And that's a cost of about $350 billion. We also know that it's going to cost about that amount of money, $350 billion, to expand surgery to meet those needs in Africa. And when you drill down into the cost of training one surgeon, it ranges between $75,000 to $150,000 per surgeon. So that's a lot of money that is required, and a lot of investment and time to train a surgeon. Now, what I would like to be able to share with you is how do we address those workforce gaps? What are some of the new tools we can use to decrease that gap in workforce training, where people don't have to physically leave their country and go to another country to learn or get training? So I would like to share with you some of the work that I'm involved with, which I think has some implication in how we're going to train the next generation of cardiovascular specialists. So at my institution, when the anesthesiology residents start their program, we first ask them to do a web-based model where they go through the whole cardiovascular cycle. They learn about the ventricle, they learn about the anatomy, the physiology, and they do a web-based model. Then we take them to a simulation model, and here you can see the simulator. And with a simulation model, they learn how to now acquire those views, the various views of the heart, various segments. We also add different pathologies to the model, so they can learn different pathological models, and they learn on the simulator. They do a number of hours with a web-based model, they do a number of hours on the simulator, and then they write an exam, an e-learning exam. Once they've done that, then they are ready to start training on patients. And the learning curve is dramatically shortened by learning on simulators, right? So I think bringing simulation into our educational platform, whether it's in the medical school or the nursing school or the physician assistant school, I think is a very good way to shorten the learning curve and to improve proficiency before going on to a patient. Now, in surgery, you might ask, well, how am I going to do that? But in surgery, you can also use what we call low fidelity models. So here is an anastomotic simulator to learn how to do a coronary anastomosis. You also have an aortic root simulator to learn how to do an aortic root or an ascending aorta replacement. And we also have a virtual model where you can actually do the actual procedure, and the camera on your computer can take a video of that, and that video can now be sent to an independent reviewer who can look at a video and score you. And we're able to track those metrics, and you can monitor your progress over time. And you could potentially learn how to do some of these procedures all on your own within the confinements of your home on a low fidelity simulator. And you could also go through the e-learning course at the same time, and again, shorten your time to proficiency. This is a piece of my research work that I'm currently involved with, where we're taking patient-specific echo models and then building 3D printed low fidelity models that we then put into a task trainer and then learn how to do the operation before we actually go to the operating room. And so this concept is demonstrated in this video, where you have a patient-specific mitral valve, which is then placed into the mitral or the task trainer. Within a task trainer, you then perform the operation that you think needs to be done. You can, after the operation is done on the simulator, you have the ability to also test the valve repair in a valve duplicator to see whether it's functioning or not, and then prepare yourself for the actual surgery, which is shown on this video. This is work done by a colleague of mine, Dr. Sadarinia, out of Maastricht. So using some of these simulator tools, I think, could also be used in Africa within our training systems to increase the proficiency of learning how to do a procedure. And as you know, in rheumatic heart disease, the mitral valve is involved in 80% of cases. And most surgeons tend to replace the valve as opposed to repair the valve. And this could be a good way to learn how to practice mitral valve repair. Now, we can take this concept and go from a 2-day training, which we call air pilot training, to building a whole curriculum around some of these simulations, and then also get certification. So this will be a scenario where we will work with the societies, the West African College of Surgeons, the Association of Thoracic and Cardiovascular Surgery, and other associations to develop a curriculum through which the residents will go through the program. And at the end of the program, we will certify proficiency, and we could give them a certificate, which will attest to the fact that they have some proficiency in, for example, mitral valve repair. Next, I would like to talk about using virtual reality and augmented reality also within the training concept, as well as with patient care, and how we can leverage some of those tools again. And that can be done through long distance. I could be here in Boston and could be monitoring a case in Abidjan and using some of these tools to guide you or to have a back and forth conversation as to how we will do this. So here is a demonstration of using the HoloLens, which is a virtual reality, augmented reality platform, where you can take different image data sets and then interact with them during surgery. You can do the same thing with using ultrasound or doing any procedure where you have the actual image as a hologram right there in front of you. And this can also be done remotely, where I could potentially be seeing what you're doing right there in Abidjan or in Accra, and be able to kind of go over the case or have a one-on-one interaction with you using some of this technology. Now, we can take this also further by using eye tracking to move images, by using your hand motion to move images and to have all the image data sets in front of you. And you can also ask for remote support or a consultation, a secondary consultation. For example, you are in Accra and you need a consultation from Abidjan, from Kumasi. You could do that with some of this technology and ask for help, right? A resident could ask for an attending or a consultant for help during the case. So those are some of the tools which I think we have to begin to start to think of how we can incorporate those into our training, into our education, into our workforce development. Now, when we talk about digital health and innovation, it's a very, very broad topic. And this is just a very, heavy laden slide, but this is just to tell you, to give you a glimpse of where we are today in the world, what's happening. 3D printing, nanorobots, robotics, handheld ultrasound. We're using AI, artificial intelligence, machine learning. We're doing genomic sequencing. We're doing all those things. And all those are data sets that need to be processed and integrated. And so it's very important that we start to think of building a data lake, a data infrastructure to be able to deal with all these data that's coming in and continuing to expand. We currently, and these are things that are currently available even in sub-Saharan Africa. Now we have blood pressures measurements of blood pressure cuffs, which are Bluetooth connected. We have handheld ultrasounds. We have point of care devices now. We have mobile EKGs. Those are things that are now available and that we can use to run remote cardiology clinics. We always talk about infrastructure, meaning that we have to have a building, but a lot of this can be done without a building from, using digital health tools. You could remotely monitor someone's EKG using some of these tools on your phone today. If you have an iWatch, you can take an EKG on your watch and send it to your doctor. You can do a mobile ultrasound off your iPhone or your Samsung or Android phone today. So I want us to kind of think of the technologies that we have that are available and how we can be a little bit more innovative in using those tools to help us to increase our diagnostic yield in managing our patients. So here I share with you, this is a wireless EKG device with an oxygen saturation. You could see that there's two sensors on the device. You put your finger on, you hold it for 30 seconds and you get an EKG strip. And then within a minute, you get a read of the EKG using artificial intelligence. And then you also get your oxygen saturation. And so this is data from my device. So that's me. You can see my name over there. Those are my numbers. And this information is kept in your phone, on your app, and you can share it with your physician, with your family member, or with anyone. And so for example, someone who has atrial fibrillation, you could use this device to capture the strip of your atrial fibrillation, and you can share it remotely. And again, I want us to think of the fact that we do not always need to have a physical structure, but we have to start thinking about how we can use some of these tools to remotely monitor people, remotely monitor populations. Here I share with you a tablet ultrasound. So this is a device, Samsung tablet, and this is an AI ultrasound probe. And then you have EKG, 3 EKG leads and a stethoscope. Those 3 units basically form a whole cardiology device, right? So you can use this device to actually do a cardiac echo. You can upload the echo into the cloud, and within the cloud infrastructure, there is an artificial intelligence and machine learning software that does the analysis and does the read for you. And this is what you will get. So you get a whole read of your echo done by an AI in the cloud on your device within 2 minutes. So this transforms basically cardiology care, because one, you do not need a cardiologist to do the read. A nurse can do the ultrasound, send it up into the cloud and get a read, a preliminary read, which can help you to figure out, does the patient have heart failure or not? Or does the patient have a low ejection fraction or not? Or must I transfer this patient to a specialist center or not? So this again are some of the tools that are currently available for us to leverage using machine learning, artificial intelligence. The next phase of that, taking it to the next phase, is what I call medical homes or remote monitoring homes. So consider yourself at home. Your doctor prescribes to you a blood pressure cuff, an oxygen saturation device, and gives you this little black box, which is called a HealthGo Mini. What that box is basically, it's a Wi-Fi box that streams the data from your devices into a platform, and that data then is streamed back to your physician. So your physician is able to remotely monitor you from home. You don't have to come to the hospital. You stay at home and we monitor you. And all you have to do is twice a day or 3 times a day, you enter information into the, you press the button on the Go Mini, and it collects all the data from your devices, right? So it collects all the data, sends the data wirelessly into a platform which your doctor will have access to. And then your doctor is able to look at what's going on. And it doesn't have to be a doctor, it could be a nurse. A nurse can look at the information and say, okay, you took your reading, everything looks good. Or you did not take your reading, we get an alarm and we call you. We say, what happened? You didn't enter a reading today. So this is what the platform looks like. You have a couple of green, yellow, red. Red, you did not take your reading. Yellow, you took your reading, but there's something, that we need to keep an eye on. Green, it's fine. So again, these are some of the technologies that now we can use to monitor patients remotely from the home. And I think that, again, we have to start thinking about leveraging the digital health ecosystem mobile technology to bring some of these tools into as part of our care continuum. Next, I'd like to talk to you about research and innovation, because we cannot always rely on external funding, external resources. We have to start to innovate within our own ecosystem. We have to start to use tools that we create within our own ecosystem. And so I would like to kind of spend the next couple of slides going over some of the work that I'm involved in Africa, particularly in Ghana, and some of the work that I'm doing here in Boston, but how we can leverage those kind of partnerships to build biomedical innovation infrastructure back in Africa. At the end of the day, I think we need to think of research and innovation around building capacity, education capacity, building biomedical engineering infrastructure, increasing the collaboration amongst South-South collaborations amongst African countries, and again, between the North and the South. And then we need to also start to think about social innovation as part of the whole context of cardiac surgery development. So this is kind of my thinking of how this happens. This is a slide from one of the chapters of my book written by Dr. Cook, who is the lead for diversity and inclusion at the Society of Thoracic Surgeons. But when I asked him to write the chapter on my book on how does he see building a global cardiothoracic surgery network, this is what he came up with, right? Being able to have a system for data collection, infrastructure for research, education and training, and then funding. And I think all those four layers are interrelated, right? You need to know, we need to know what the numbers are. How many people need surgery? What's the population of the folks in your country? How many surgeons do we have? How many perfusionists do we have? We need that data. So I think one of the things that I would like to emphasize from my talk is we need to establish registries, cohorts, to be able to understand what the data is. Without the data, we cannot proceed to the next layer. Without data, you cannot go to your politician, to the government, and ask for funding. When they ask you how much funding do you need, what's the answer you give? So again, we need data to move on to the next phase. So this is one of the core things that I think I would like to emphasize: creating a registry, maybe country registries, to collect data on what the capacity of our cardiovascular capacities are. Next, we need to build research infrastructure. By research infrastructure, what I mean is that as a society, we need to start thinking of creating research money that we can give grants for doing certain research, you know, on rheumatic heart disease, on congenital disease, on heart failure. If we don't start ourselves, we cannot ask others to chip in money when we haven't got a framework to do that. So we need to establish a research framework within the society, within our countries, where we can start to fund certain research projects that are locally based. And then we can now go to the NGOs and to the government to ask to increase that funding. But we need to start somewhere. Next thing, we talk about education and training. And that can be in-person training, that can be online training, that can be simulation training. I think we're gonna have to start merging the two: in-person, simulation, e-learning. We need to also figure out a structure to do that. And then finally, one of the early speakers talked about industry funding. Professor Ngate mentioned funders, private funders putting a certain percentage of their monies. Professor Tete mentioned the same thing. Again, we have to build that. We have to build that infrastructure that makes it possible. What I call socially responsible initiatives, right? That makes it possible for governments and private enterprises to feel socially responsible to taking care of patients that have cardiovascular disease. But that has to start with us. Now, I'd like to share some of the work that I'm also doing in Ghana, leveraging the tools that I shared, the ultrasound device that I shared with you, the point of care device for diagnosing heart failure. And what we're doing right now is we are trying to implement a strategy for training nurses and physician assistants. We believe that the next generation of learning, we have to, what we call task shift, right? Task shift. If we can use artificial intelligence and machine learning and incorporate those into some of these devices, then a nurse can actually make the diagnosis at the point of care. And her job is then to say, well, I think you have heart failure. I think I need to refer you to the cardiologist, or I need to refer you to the primary care physician. We do not have enough cardiologists and surgeons in Africa. And so we have to find a way to train more people in the thousands to be able to increase the capacity. And so our research project that we are hoping to be able to implement is that we are going to be using some of these tools to train nurses to learn how to use the ultrasounds, to actually do the ultrasounds using artificial intelligence guidance. And then once they do the ultrasound, the AI will calculate the ejection fraction and will either give them a yes or a no. Heart failure, yes, heart failure, no. And once you're able to triage those patients, then you can improve your care with guidelines. So again, these are things that I think are implementable within Africa, and this is some of the work that I'm involved with. The same concept has been done in Belize, where they've actually now adopted some of these concepts within their national health system. And so to the point where we can introduce some of these tools into our national health system, where someone in the periphery can do an echo, send the images into a cloud infrastructure, and a remote cardiologist can read, make a diagnosis, and then send the information back to the periphery for the treatment of the patient. So again, I want us again to think about not just always having a physical structure per se, but to think of using the digital health infrastructure that is kind of robust in most African countries. I think most people have a mobile phone. Perhaps there are more mobile phones in Africa than the rest of the world. I don't know that you all know that, but Africa is the leader in mobile phones. And Africa also is leading in mobile money, right? So there are a lot of leaders in Africa. There are a lot of good things happening in Africa. And so we need to use, what we're good at, mobile money. We're good at mobile money. We have mobile phones. We have a good, mobile system. So why not leverage that to build digital health infrastructure that's incorporated into the national health system, such that we can now diagnose at the periphery, where patients don't have to drive all the way to the city to see a cardiologist. So that's kind of the thinking that I hope that at the end of my talk, you will get. This is a project that is ongoing in Ghana. In fact, Professor Tete is one of the investigators on this study. where we're using digital health to monitor hypertension. We're able to screen them for hypertension. We're able to remotely manage them and e-prescribe. We're piloting this in Accra and in Ho, and we partnered with the Ghana Health Service, and we are hoping that at the end of the study, this is a project that can be scaled at the national level. And again, I think that some of these tools need to be piloted first. And then once you pilot them, once you've been able to see what the outcomes are, and if they are good, then they can be scaled within the national health system. So again, I think that there are ways through which we could do this through collaboration and partnership, where we can leverage some of these technologies to improve the health of our patients. So this is kind of the platform that I'm talking about, where you record your blood pressure. The patient has an app, they can record their blood pressure. We can also see it from the physician side. And then we can build analytic tools from the data and use those analytic tools to look at the disease prevalence, their risk scores, and their prescription data. So we can see their, if they're filling up their prescriptions or they're not filling up their prescriptions, what is the most common medication that they're taking. So we're able to do some of that through data analytics. And the same thing can be used for research. You could use that same data that you've collected for over thousands of patients into building longitudinal patient data and building our own research infrastructure and knowing what our numbers are. We do not always have to wait for someone from the West to come down and tell us what our own data is, right? We have to be able to do that on our own. So again, these are all ways and means by which we can start to build our own research capacity in country. I would like to, towards the end of my talk, I mentioned registries, right? And I still believe that this is one of the most important things we need to do. We need to start building registries to map out the workforce, map out the infrastructure, map out the service delivery and the costing. Without those numbers, it's difficult to ask funders to fund. It's difficult to ask for research money. It's difficult to ask for all the things that we want. So I would, again, reemphasize the fact that if anything at all, at the end of this meeting, that we focus on building our own registries to identify what are the gaps within the workforce, within the infrastructure, within the service delivery, and then be able to map out the costing. Some may call it a modified INSOP. The INSOP, as we've mentioned, does not account for cardiac surgery. Cardiac surgery is unique in the sense that it has its own, there are a lot of other things that need to be collected, but whether you call it INSOP, whatever you want to call it, as Professor Donko mentioned, these basic 4 tenets need to be figured out, and we need to start collecting data on those. Now, in terms of innovation, that's a passion of mine. I'm not an engineer. I wish I'd done some engineering in high school, in university, but I've gotten drawn to a lot of innovation over the last few years. But I believe that innovation has to happen locally, right? So it's not okay for us to bring in always technology from the West and then bring it down to Africa and say, well, look, here is what we've given you. You need to use it and use it as we've suggested. I think that we need to, what I call co-create technology, right? We need to together develop technology. So this is an example of a very low cost low-cost ventilator, if you want to call it that way. This is something we developed during the COVID era. When COVID started, if many of you may remember that ventilators became a problem. Globally, there were no ventilators. So a group of us came together and built this low-cost unit, very low cost to build, most of it 3D printed. And we did a few of those pilot studies in Ghana. And we've published it in the Annals of Thoracic Surgery. But this is one of the low-cost innovation, which I'm kind of very proud of, because it involved working with both, North and South collaboration, all of us working together to make this happen. And I think that's kind of the idea that I want to kind of bring out, that we need to start thinking about how we're going to innovate locally. And one of the areas that I think is very important, and Professor Lee mentioned it, is how we're going to build our own valves. We have 34 million people with rheumatic heart disease. And mind you, the valves that are on the market are not suitable for rheumatic heart disease. Mechanical valves, you need to be on Coumadin for the rest of your life, right? Tissue valves, they will degenerate in 5 years' time. So the valves that we are using right now are not appropriate for rheumatic heart disease, but we have no choice. We have no choice because that's what's on the market. And secondly, those valves are very expensive. So one of the things that I'm working on with a group of colleagues is what we call a polymeric heart valve. It's a valve made of a polymer that will not require anticoagulation, will last for the rest of your lifetime, can be 3D printed and can be manufactured in Africa, right? You do not need to cold store it. So this is kind of the work. The next 5 to 10 years, most of my energies are focused on how do we build a low-cost valve that can be implanted without opening the chest and can be manufactured right here in Africa. And I hope that the leadership from the ECOWAS, the African Development Bank, the African Union are listening, because this is a partnership that can be done together, where we all, just like we're doing for vaccines, we put emphasis on we need to develop this for our own people in country as a North-South collaboration. And so this will be one of the things that I would like to be able to see happen, going forward, where we can work together to build a valve for our own people right here in Africa. This is what that kind of valve looks like. This is from Professor Dassi's group. He's been working on this also for quite some time. And we are working on it also in Boston. We've got a nice platform that we think could be useful to deliver this non-invasively. But basically, this is what it looks like. It's it's made of a polymer. Hyaluronan is a glucose-based polymer. And we figured out the exact composition of the polymer such that it's not degradable and it will last. We also know that that polymer is resistant to thrombosis. There have been some initial studies that have shown that it's implanted in animals. There was no need for anticoagulation and the valve works perfectly fine. So more to come on this technology, but this is one of the things on the horizon. Then further to that is what we call, tissue generated valves, where we develop a scaffold, a biodegradable scaffold, and we allow your own cells to infiltrate that scaffold and make it a valve. So this is what we call 3D printed regenerative tissue valves. This is a project that we are also working on with the view that we will implant a biodegradable polymer in a minimal invasive way and that your cells, just like for wound healing, will then infiltrate into that polymer and cover that whole polymer. And then we can program the biodegradable polymer to, within maybe a year or two, to disappear. And so the rest is just your own tissues. So again, this is new, I wouldn't call it new technology, but this is what we call regenerative medicine. And these are some of the areas where I think there's a lot of opportunities to collaborate and to do some of that research in Africa. This is a tissue engineered valve from the Kit Parker's group at Harvard, where they are also building tissue regenerating valves. They've implanted them in sheep with excellent results. So again, I think you're going to be hearing more of this. And this is going to be very important for the congenital population, because as you know, when you replace a valve in a child, one of the problems with children is that they grow. And as they grow, you have to replace that valve because they've outgrown the valve. So these kind of valves will actually grow with the children. As they are growing, the valve also grows. And so this will actually replace a lot of, or will prevent a lot of unnecessary surgeries, particularly in kids with valvular heart disease or kids that have TOF, tetralogy of Fallot, where you have to replace the pulmonary valve. So again, it's all exciting stuff that's on the horizon. And those are things, again, that I think that we can all partner together to be able to move forward. So we've talked a lot about, what we need, what the gaps are. Where do we go in the future? In the future, I think I've clearly outlined to you what is happening in the era of simulation, in the era of augmented reality, virtual reality, telesimulation, telesurgery, telerobotics, point of care ultrasound, point of care EKG devices. All those things are happening. This is not, it's not sci-fi anymore. It's actually what is happening. So we need to now figure out how we're going to move forward, how we're going to incorporate some of these tools into our cardiac surgery, continuum. And I think one of the big things that, and many of the speakers have mentioned it before, is we are going to have to collaborate. We are going to have to stop thinking about me and you, and it's going to have to be we. And the moment we start to think about we, 1 + 1 does not become 2, 1 + 1 becomes 5. And so again, I still want to hone in on this message of collaboration, partnership, building the data infrastructure for us to collect data, to understand what our infrastructure is, what our workforce is, what are the financial gaps. Once we have data, once we collaborate, we will find the money somehow, whether it's from the government, whether it's from grants, whether it's from NGOs, whether it's from private enterprises, we will figure it out. But we cannot do that without the basic data. And we cannot do that if we do not collaborate. And we cannot do that if we do not have a society vision. And we cannot do that if together we don't work as one. So those will be the big ticket items I want to leave you with. Collaboration, South-South collaboration, North-South collaboration, and how do we make that happen? I'll leave that to the leadership of the West African College of Surgeons and to the leadership of the African Association of Thoracic and Cardiovascular Surgery. But I think this is very important for us to go forward for all the other things to happen. I think we've talked about regionalization of centers. We've talked about building heart teams. We've talked about building centers of excellence. We've talked about all those things. Nothing is new, but I think together we can do it. And if we change our thinking to start thinking more health system wide, as opposed to just surgery or a building, start to think about digital health, start to think about ways to augment education, e-learning, e-learning platforms. I think we can do a lot. We can do a lot together. This is a slide I show in there. How do I see that future happening? Collaboration, tele-simulation, tele-imaging, 3D printing, virtualized surgery, cloud infrastructure, AI, ML. And this is where it's all going to end up. And this is from my friend Sadari Nea, who is actually built a telemitral valve simulation program, where you can be in Abidjan and learn how to do a mitral valve and go through the whole curriculum, all using virtualized telesimulation platforms, right? You don't have to move. You don't have to travel anywhere. You'll be in your home. You can do this in the comfort of your home. We can build a curriculum for you, whether it's aortic, mitral, coronary anastomosis. All you need is a Wi-Fi connection, and all you need is a camera and your tablet. And this whole system is 3D printed, by the way, right? So we can print it, 3D print it, and send it to you. But again, I want you to think about how we can use some of these tools to augment education at the college level, at the society level, not just in one country, but across Africa. And this is one of the areas that I'm very passionate about, and that I hope that we can work together to move this forward, not only for cardiac surgery, but even for other aspects of surgery. So in conclusion, this is kind of this is the money slide, right? This is where I think we need to kind of leverage all the technologies that we have to improve training, increase training, improve research, education. We need to create a coalition of stakeholders, cardiothoracic surgeons, cardiologists, anesthesiologists, industry. Industry is key, governments, donors, policymakers. We need to do that. And that has to go in parallel with the other things that we've already mentioned. And then we have to find a way for that knowledge to transfer to improve patient care. At the end of the day, it's all about the patients that we serve. We don't do it for ourselves. We're doing it for our patients. And so if we open our minds and think big and work together as collaborators, I think we can do quite a lot in Africa. And I'm optimistic. I'm from Africa. I will remain an African. And I look forward to working with all of you on this vision and on the vision of the society, as well as the West African Coalition of Surgeons, and as well as for the African Union. So with that, I would like to thank you all for the attention and the invitation to present at this meeting. And thanks again for the opportunity. And I'd like to hand over to Professor Ngate.
Thank you so much, Jack, for this splendid presentation. I don't think we'll have any question for you. We are dreaming, and it's quite amazing what you have to present to us, the future. Thank you so much.
Thank you.
We are going to look for the lunch, and after that, we'll see you again.
We'll see you soon.
Thank you. Bye-bye.
Bye.
See you in I think in 45 minutes.
I'll see you there.
For the rest of the program. Thank you so much. Okay.
Recording stopped.